So multiple gestation is also called multifetal pregnancy. Okay, so another terminology which is used is multifetal pregnancy. So women carrying multiples are subject to significant changes in maternal physiology beyond normal pregnancy adaptations because of the extra number of fetus. You need to supply more blood to keep both of them alive, or even the triplet or quadruplet, whatever number is, the extra number always requires more nutrition, more blood supply. So maternal resting energy expenditure in twin pregnancies increased by 10% compared to the single-term pregnancy. So you have to make a thorough good antepartum assessment here. So given the risk of fetal growth restriction and growth discordance in multiple gestations, serial growth ultrasounds are recommended beginning in the second trimester. So once you know from the anomaly scan, which you do usually at the 12th and 21st week of pregnancy, that time itself you will know whether there is a single fetus or a multiple fetus. So once you know there is more than one fetus, serial growth ultrasounds are recommended beginning in the second trimester. And in monochorionic twins, ultrasound should be performed every 2 weeks to look for evidence of twin-twin transfusion syndrome. Whereas in dichorionic twins with concordant growth scans can be performed approximately every 4 to 6 weeks in the absence of any other pregnancy complications. This is about the monitoring the growth of the fetus. Multiple gestations are having increased risk of stillbirth. So if the stillbirth is there, there are more chances of postpartum complications like infection, PPH, all these things are more common because of stillbirth. Then the second thing is, what is the timing of delivery? Should you allow the full gestation period to get over, or should you deliver early? Is the next important dilemma. So monochorionic diamniotic twins, which have two separate amniotic sacs, have been shown to have increased perinatal mortality throughout pregnancy and even at term compared with dichorionic diamniotic twins. So the increased risk of stillbirth in monochorionic twins may be partly attributed to complications from twin-to-twin transfusion syndrome, although stillbirth rates due to congenital anomalies and antepartum hypoxia are also significant causes for this problem in monochorionic twins. Association of Committee of OG recommends the following terms in timing of delivery. Uncomplicated dichorionic diamniotic twin gestations, you can think of delivery at 38 weeks of pregnancy. Until such time, you can allow the pregnancy to go on. Whereas in uncomplicated monochorionic diamniotic twins, it should be between 34 or 36 to 37 weeks. In an uncomplicated monochorionic monoamniotic twin, that is same amniotic sac, there are two babies, then delivery should be ideally performed between 32 to 34 weeks. Do not allow, because the rate of stillbirth is higher when you allow it to grow beyond that period. So these are all the various descriptions of the twins: monochorionic, monoamniotic, monochorionic diamniotic, dichorionic diamniotic, and dichorionic separate placenta also is separate. So single placenta with the two sacs also can be there. And what is the mode of delivery you should do? That is the third thing. So antepartum hemorrhage, antepartum ultrasound for serial growth estimation. Second thing is the maximum allowable time for the gestation to go on. Third thing is mode of delivery should be decided well in advance. Should be determined by the position of the fetuses. So it can be vertex to vertex twin presentation occurs approximately in 42% of the twins. So a trial labor is generally accepted in this situation, with delivery occurring in a setting that allows efficient conversion to cesarean section for the second twin if needed or indicated. So you can always give a chance for the mother to deliver normally. Caesarean delivery is usually indicated in the presence of non-vertex twin presentation, especially monoamniotic twins and higher order multiple gestations due to lack of evidence regarding the safety of a vaginal delivery. So if there are more than two, triplet or quadruplet, it is always better to go for an elective caesarean and not allow normal vaginal delivery. For the vertex, non-vertex presentation, like one baby vertex, another baby breech, several options are available, including caesarean delivery of both twins, attempted cephalic version of the second twin, or a breech extraction of the second twin. So these three possibilities are there. Now, what are the maternal adaptations that happen when there is a multiple gestation? These are all the physiological, exaggerated physiological changes. What normally happens with a single fetus, they are all exaggerated. So cardiovascular system, heart rate will increase more than the normal single pregnancy. Similarly, cardiac index output also increases, stroke volume increases, contractility increases, and increased severity and the earlier onset of supine hypotensive syndrome. This is a very important point. Normally, in a singleton pregnancy, it starts only at the 20th week, but here it may start much more earlier. And respiratory system also, there is an increase in tidal volume, increase in oxygen consumption. So these mothers desaturate much more rapidly because they consume more oxygen, and their FRC is also equally much more compromised. In the central nervous system, two dermatomes, greater spread of spinal anesthesia will happen. And in the hematology, 400 ml greater of increase in blood volume and increased incidence of anemia and thrombocytopenia. So these are all the things that happen compared to the normal pregnancy. And complications in multiple gestation pregnancy are preterm labor and delivery. Hypertensive disorders are more common when the mother is having more than one fetus. Gestational diabetes is also more common. They can suddenly go for pulmonary edema because of the fluid overload that they have compared to the singleton pregnancy. Sometimes they may require urgent cesarean delivery even in the antenatal period before the expected date. Antepartum and postpartum hemorrhages are more common, and peripartum hysterectomy has been reported in several cases because of bleeding and uterine atony. And maternal and perinatal death also has been reported. So these are all the complications of multiple gestation pregnancy. Now, maternal hemorrhage is another important factor which you have to take into consideration. Multiple gestation pregnancy has got a blood loss of more than 900 ml, even with the vaginal delivery, similar to that seen in cesarean delivery. Normally, in a singleton pregnancy, vaginal delivery causes only about 500 ml of blood loss, whereas cesarean delivery may lead to up to 900 to 1000 ml. Whereas here, even in the normal vaginal delivery, the blood loss may be more than 900 ml. And placental abruption is 3 times more likely among twin pregnancies compared with singletons. The rate of postpartum hemorrhage is doubled in multiple gestation pregnancies due to abruption or uterine atony or hypertensive disorders. So this is another important point we have to keep in mind. And the PTH protocols can guide management of this potentially life-threatening event. So after that, you have to keep an eye on the airway consideration. The PTH protocols is the following things: airway considerations, readily available equipment like intravenous access, rapid infusers, warming blankets, and massive transfusion protocols according to the institutional guidelines, and uterotronic drugs like oxytocin, methergine, misoprostol, and all that. And regular protocol drills are important because the twin pregnancy deliveries are not very frequent. So you may be caught unaware if you are not ready. So for that, just like your failed intubation drill, which was described by Michael Tunstall, you have to know about the regular massive transfusion protocol also. Then sometimes there may be need for fetal surgery in the maternal twin multiple gestation. So recent advances in the management of the twin transfusion syndrome makes it likely that fetoscopic laser therapy may be performed sometimes to salvage the fetus. And one potential complication of that is what is called mirror syndrome, causing maternal eye drops. That is, mother will develop a lot of edema and oliguria and hemodilution. So this is a maternal complication due to the twin-to-twin transfusion syndrome. And mirror syndrome may be mistaken for preeclampsia, but the presence of fetal eye drops may direct the diagnosis. So the baby, one baby will have an edema, as you said, the other may be the depleted one. The management of mother with mirror syndrome includes consideration of volume status, cardiovascular function, and use of appropriate hemodynamic monitoring. Neuraxial anesthesia is a suitable option. However, general anesthesia may be necessary, and the airway edema may increase the risk of difficult airway management in these sort of cases. So, if there is a twins and if there is a diagnosis of twin transfusion syndrome, always look for the mirror syndrome in the mother, and when you give GA, be careful about the airway. And maternal morbidity is due to anemia, hemorrhage, hypertensive disorders, preeclampsia, thromboembolism, which are more common in multiple gestation pregnancies. So rise in multiple gestation pregnancy, particularly among women with advanced age or patients who had infertility treatment. So multiple gestation is much more common nowadays in people who undergo infertility treatment. So contributes to the recent observation of rising maternal mortality. Other concerns are multiple gestation pregnancy is more likely than single pregnancy to be delivered by cesarean delivery. So planned elective cesarean is always safer. Multiple gestation may be associated with postpartum depression also in the mother. Now, preterm birth in multiple gestation pregnancy. What happens when predicting the preterm birth can be done by cervical length, fetal fibronectin, home uterine monitoring, and digital examination are modalities used to predict the preterm birth. Now, what are the pharmacological therapies to prevent preterm birth? Corticosteroids may not be beneficial in multiple gestation pregnancies at risk for preterm birth, but tocolytics to prevent uterine contractions like beta agonists or ritotrin, of course, it's now not commonly used. Terbutaline or calcium channel blockers may cause maternal tachycardia and hypotension and electrolyte abnormalities, also hyperglycemia and hyperkalemia. Epidural anesthesia can be used to relieve cardiac efforts associated with this condition. And magnesium therapy is also used not only for as a treatment for preeclampsia, in preterm birth prevention also magnesium therapy is used as a neuroprotective agent for the fetus up to 32 weeks. Coming to the anesthesia for vaginal delivery in multiple gestation. Now comes the options of delivery management. Vaginal delivery, epidural use for twin delivery may improve maternal relaxation to avoid premature pushing and enable breech extraction, and also if extended for to converted or to cesarean, we can continue with the epidural by giving a higher concentration. For anesthesia personnel attending the twin delivery, preparations for emergency transfer to the operating room and emergency cesarean delivery considerations very important. You have to always be on the alert for this. And anesthesia for cesarean delivery in multiple gestation. Earlier we saw for a normal vaginal delivery, always use epidural so that it will be useful as a pain reliever and also help in the uterine relaxation for any altering the position of the second fetus. Whereas for planned or emergency cesarean delivery, multiple gestation is frequently performed under neuraxial anesthesia. If it is an elective procedure, you can straight away go for your regular neuraxial technique. Whereas if it is, and left lateral should be used in all pregnancies because of atrial cave compression, which will be more severe compared to the single pregnancy, and it is more exaggerated in multiple. Whereas unplanned cesarean delivery is one where you get caught. When it may be associated with emergency indications such as cord prolapse or fetal bradycardia. These are all the situations where even if it is a vertex presentation, both the babies are vertex, you have planned for a vaginal delivery. But suddenly, because of cord prolapse or fetal bradycardia, you may be taking up that patient as an emergency cesarean delivery. So an epidural catheter placed for twin delivery can be extended to provide suitable and timely surgical anesthesia. Epidural failure or urgent surgery may necessitate general anesthesia. So if there is no time to place an epidural catheter, or the catheter that has been placed is not giving a satisfactory pain relief, then KA may be necessary. So when that is the indication, you have to be doubly careful with all the regular preparations like acid aspiration prophylaxis, and the pre-oxygenation should be adequately done because they desaturate well faster, and all the other routine of managing a patient for GA. We saw in the earlier one the routine use of GA for cesarean section is coming down nowadays because of the universal acceptance that even for category 1 cesarean section, you can do what is called rapid sequence spinal, which we saw in the last discussion. So the uh, application of general anesthesia for cesarean delivery is becoming rarer. So one must be quite clear as how to do that and be aware of all the problems that are there. So in a twin pregnancy or a multiple gestation mother, the important things are pre-oxygenation, adequate left lateral tilt to prevent supine hypotension syndrome, and thorough evaluation of the airway, and avoid any intubation difficulties, and be watchful for hemorrhage and postpartum complications like PPH and other things which can happen in these patients. Okay, so these are the points that you can just remember. Of course, this is not a full detailed explanation, but most of the important points only I have just taken as a guideline for improving your presentation. Okay.